It is a real pleasure to be here with you again. And I think we have some sort of exciting updates, and I'm optimistic about the future. So I'm happy to be here. You've probably seen the data from Massachusetts. Numbers are really finally trickling down after this last Omicron. We are coming down with respect to overall diagnostic numbers, hospitalizations. Deaths always lag a few weeks behind the peak, and so we're sort of beginning to come down on the death rate, but overall looking good. And these numbers are actually similar throughout New England. They are fairly regional. The overall US numbers are trickling down as well, but regionally we're looking pretty good. Now, my second favorite set of numbers are the Massachusetts wastewater numbers. I've never seen so many people excited about wastewater, which is really just looking for COVID in the sewage. So, way back in the beginning of the pandemic, we had a little blip. The numbers in peach, or the dots in peach, are from the southern collection of Massachusetts wastewater, and then the green are from the north. And you can see that, like in the beginning, we had low level in the wastewater, and then we had that surge last winter, and then we had just like this crazy surge with Omicron. So really high numbers, but then very, very nicely coming down. And so we are all very optimistic, and we've been optimistic for weeks, that this usually precedes us seeing a clinical decline in numbers. So overall, this is really good news. And hopefully this will continue to decline, and we'll get, just lower and lower and lower. So things that I wanted to highlight are that there will be, it's not quite formalized yet, but the CDC Advisory Committee on Immunization Practice has some important updates that I wanted to review with you. I'm actually a voting member on the CDC Advisory Committee on Immunization Practice, and I've been helping drive some of the change that I will talk about. So you're probably all familiar that as part of the primary vaccine series for heart transplant recipients, it was recommended that everybody have 3 doses as part of their primary series, followed by a booster. And initially we said a booster after 6 months, and then it went to 5 months. And then as of last week, we talked at the meeting about how the recommendation, that again, isn't quite out yet, but should be out in the next week. So hopefully within the next 1 to 2 weeks, CVS and others will follow, but basically for a booster dose 3 months after, at least 3 months after the 3rd dose of the primary series. So I call this kind of 3+1, and the +1 should now happen within 3 months after the final dose of the first 3. But right now, if you walk in the door of CVS, they're going to say it's 5 months. So it is a little bit of a lag time. But what we were seeing is a lot of breakthrough infection with Omicron. And so we wanted to give people an earlier booster to try to avoid those breakthrough infections. Here's another visual on what I'm talking about. So for either Pfizer or Moderna, it was 3 doses, 1, 2, 3, either 21 to 28 days apart. And then a booster dose, which now will be 3 months or more later, but a total of 4 doses. So hopefully everybody's getting 4 doses. For J&J, it's a little more complicated. We are recommending an additional dose of vaccine 28 days or more after the first dose. We do prefer either Moderna or Pfizer as that additional dose because we think it's better. And then a booster dose of either Pfizer or Moderna at least 2 months later. So J&J folks should be getting a total of 3 vaccines. Pfizer and Moderna people should be getting 3 plus a booster, so a total of 4 vaccines each. So the rationale for all of this, and discussed at the CDC meeting, was that over time, people do lose protection. We know that people who are on transplant-related immunosuppression lose protection from vaccine, and are higher risk for breakthrough disease, especially when there are very heavy rates of community transmission, as we saw during Omicron. And in smaller studies, we saw that a fourth dose is in fact useful, and that's been published in multiple different places. And I'm personally in contact with many of those authors in Canada and Israel and France and talking about that data. And then there are multiple studies showing additional booster effect within 3 months of the primary series. And then several countries have implemented that. As I mentioned, Israel, France, Canada, and others are now doing this additional 3-month booster. So the CDC was comfortable with that data and said that that's what we should be doing to better protect our immunocompromised patients. Something that really exciting that will come out of the meeting when we have official guidelines, hopefully within the next few days, but is that previously doctors were not allowed to have any leeway in any of the medical decision-making around individual patients and the COVID vaccines. So if somebody, say, came in and got treated for rejection, so had high doses of immune suppression and then had a COVID vaccine at the same time, which doesn't really make sense. And like I would say, probably we shouldn't count that as a real vaccine because they're unlikely to have a good immune response. Now we are allowed to make decisions based on medical judgment. And so we can change the dosing interval and the number of doses given if we think it's in the best interest of the patient. So this is actually wonderful. It took a tremendous amount to push this through, but we're really excited about this, that clinicians will have flexibility. Now, the other thing I wanted to talk with you about is Evusheld. So Evusheld is a preventative monoclonal antibody. Probably many of you have heard of it. We are giving it to people with suppressed immune systems. And it's kind of in addition to vaccines, it's basically providing passive immunity. It's like you don't have an immune response to it, like with vaccines. It just provides protection just by being there. It's 2 injections, like either 1 in each arm or 1 in each butt or whatever. I've personally given a bunch of the injections, very well tolerated. And it is, for people on this call, recommended. Our top tier is solid organ transplant people within 10 years of transplant, or especially those that have been recently treated for rejection. And then in the second tier, so we're getting through the first tier at Mass General, trying to give it to all of those patients at highest risk. And then we're also starting to give it to people who had organ transplant more than 10 years out. My recommendation is that everybody still get a booster dose. So if you haven't had your total of 4 vaccines, you should get your booster, and then you should get Evusheld 2 or more weeks later. So that's an important thing. So I'm still going with vaccine because it provides both antibody and cellular immunity, and I think it's more robust. Now, there's been a lot of kind of confusion about antibodies and Regeneron antibodies and Citruvimab and all kinds of things. So they've currently distilled the guidance. So the only time that we change anything is as I mentioned, we try to give booster vaccine and then wait to give Evusheld at least 2 weeks later. So a lot of the antibody stuff is going to be clarified. And I just want to briefly mention, sorry, this is a really busy slide, but basically it talks about treatment for early COVID-19. And hopefully nobody on this call will actually need this, but if you do, we have monoclonal antibodies. We have Evusheld, as I mentioned, for prevention of infection. So that's not if you were exposed, but it's basically used sort of like a vaccine, really just to prevent disease. And then Citruvimab in that orange is a monoclonal antibody that we are using for treatment. And it is very effective, tolerated really well, and what we are using mostly for transplant patients. Because then if we think about the antivirals that are available, remdesivir is the one that's intravenous. We really don't have the capacity to give it as outpatient treatment, but it is given to almost all people admitted to hospital with COVID-19. And then Paxlovid is another antivirus treatment, like an antibiotic, but antivirus. Paxlovid is very effective, 89% effective in preventing hospitalization or death. in unvaccinated people, but it has tremendous drug-drug interactions. So in general, we are not using it in transplant patients. Molnupiravir, which is the Merck drug, is only about 30% protective from hospitalization or death, so a lot less protective than the 89%. And in general, we're trying to avoid this in transplant patients, and we'd rather go with Satruvimab that's 85% protective. We do have an algorithm. Again, this is a busy slide, but what I really wanted to say is call your primary care doctor, call your heart transplant team. And if you're within the Mass General Brigham system, they just put this order in. And I know that at Tufts, they're doing the same thing, that they just put an order in, and there's a scheme where then people on the back end get those orders, and we contact the patient and we organize for monoclonal antibody or drugs or whatever they need. And that's how I spent my afternoon, is calling those people who are sick and figuring out how we are best going to get them those treatments. And I wanted to just finish the slides by just showing you this infographic that I thought was just great information. This is real life data on masking. And so this was 534 people who reported that they always wear a mask in indoor public settings. And then how much does this help decrease the risk of testing positive for COVID? So compared with no mask, cloth mask decreased the overall risk by 56%. So it's like pretty good, right? Pretty good. Surgical mask decreases the risk of being positive for COVID by 66%. And then N95 or KN95 decreases the overall risk by 83%. So this is what we call real life data. You know, if you're thinking what the best mask for you might be, I think that this helps with that risk equation. Thinking about, and this is overall measured for weeks and weeks and weeks. So this is not just like one day, but you know, overall wearing these different masks, which masks decrease the risk over time of people who always reported wearing masks in public settings. And obviously the N95, KN95 is the best. But I would say any mask is a huge difference compared to no mask. And that's it. So that's it for the slide section. But I know that people, I'm sure people have a lot of questions, and I'm happy to have questions and hear your thoughts.
So Dr. Kotton, here's the first question. And please, if everybody just put your questions in the chat, I'll get to them and ask Dr. Kotton. So question, you mentioned the 4th dose of the vaccine. Is that correct? Or is it for immunocompromised individuals only, or general population?
That's only for immunocompromised. For the general population, it should be 2 vaccines plus a booster 5 or more months later. We haven't changed for the general population.
Okay. I have heard that Moderna and Pfizer are developing new vaccines formulation for Omicron. Is that true?
I believe that is true, but I would not hold your breath and do not wait for that vaccine to come out. It is much better to go ahead and get the vaccine that you should get now. And then, yes, maybe we'll be giving Omicron, but many of us think Omicron's kind of flash in the pan. And by the time the Omicron vaccine is fully ready, it may be a thing of the past. I know, crazy, right? Hard to wrap your head around. Regarding the fifth shot, undoubtedly there will be a 5th shot. We don't know the timing of that yet, because we just made the rules for the 3 doses of vaccine plus 1 booster. And I said to the CDC that when I spoke to them this week, we need to know when the next vaccine is going to be. And they said, yeah, we're working on that. So we're not quite sure what that answer will be. And then what is the new strain? There are a couple new strains circulating out there. We're going to see what strain rears its ugly head. When can you get your 4th shot, Phil?
Yeah, because I had the monoclonal antibody treatment, and you told me to wait 3 months.
Okay. Well,
I thought that changed. That slide you put up earlier.
Yeah, you could probably, so you're probably well protected for a couple of months, but you should probably maybe like 2 months out, get it.
2 months out, okay.
Yeah, yeah, 6 weeks, 6 to 8 weeks.
And then get the Eversheld or whatever it's called after that?
Yeah, yeah, that's like a whole cocktail, like a whole sandwich.
I guess.
Yeah, you should be well protected. A little bit to be determined on what happens in the spring. Like right now, we sort of don't fully know what's going to happen in the spring.
Yeah, it's always
But
changing.
that sounds like a good plan.
Okay, all right, so I'll only wait a couple of months then, so
Yeah, that sounds good.
get the vaccine. All right, thank you.
Yeah, seems like a good idea.
So, Dr. Cotton, that's a personal experience. I went to Rite Aid to get my
Yeah.
shot, and they said they had no corporate directive to do that. I went a number of times, and then I went over to the grocery store next door that had the pharmacy, and they said, "Oh yeah, sure, just go on the web, schedule it, and we'll give you your first shot." So I don't know if the word's getting out to, especially to the big change, that they should do that.
Yeah, so I've heard that it's been hard for the big chains. So now that I work for a large institution called Mass General Brigham, it turns out it's really hard to make these big institutions nimble and to turn on a dime. And so I've heard that frequently, that some of the pharmacy chains or some of the pharmacists and things, people were not up to date. So it's listed under the clinical considerations. It's hard for me to tell you what to do, but I mean, I would say I would show the pharmacist and say like, here's the CDC guidelines. Look, here's my vaccine stuff. Like, okay. But I do understand they don't want to break the rules. We've done a lot of work behind the scenes with the CDC, communicating with those pharmacies and saying like, hey guys, upgrade your computer systems, upgrade the recommendations. But I've heard it's still a problem. I think it's going to be a problem again, because we just went from, in December, we went from a 6-month booster to a 5-month booster, and that was a pretty big deal to get done. And then now we're going from a 5-month booster to a 3-month booster for immunocompromised people, and that's just going to confuse them more. And then the part where I said that clinicians are going to have flexibility means, like in theory, you're going to walk in and say, my doctor said to come in for another dose. And I'm wondering, and I've been asking the CDC how that's really going to roll. But so it's a work in progress. I apologize for the computer systems that have not been reprogrammed quickly enough, or the brains of the pharmacists at Rite Aid who have not been reprogrammed quickly enough. It is very hard to stay up to date in the pandemic. So where am I up to? Somebody got Steve got his 4th shot at CVS. That's great. And then is the vaccine going to be like a flu shot? Going to get this every year? Yes, probably, but to be determined. I can't predict the future. We've never had a pandemic like this, but most likely. And should Evusheld be given to all heart transplant, everyone who's had a heart transplant within the past 2 years? Probably. I don't want to go too far out on a limb, but like most likely, unless there's a contraindication, yes. And is the 4th shot, the 3 initial shots for immunocompromised, or 2 initial shots plus 2 boosters? Yeah, so, okay. This is a great question from Anthony. So, right. So if you underwent heart transplant this year and you had 2 before the heart transplant, do you get 1 afterwards? I say more is better. So basically try to get 2 more, probably 3 months apart, because now you're immunocompromised. So that seems like a good idea to me. That's what I would want for myself. And it's kosher, because it's like now you're immunocompromised. So you can say, well, I tick the immunocompromised box. So I think that's, I guess I would talk to your transplant team and make sure they agree, but that would be my general recommendation. And then Patrick Sullivan says, I read that J&J is stopping vaccine program. I have not heard that news. I do think that J&J has, they tend to have a little more cellular immunity, which is different than the antibody immunity. I'm not sure where they will fit into the overall vaccine array. So it's an interesting question, but so far we don't know the answer to that. There are going to be some new, more traditional vaccines kind of on the same platform or the same, they're like the influenza vaccines. And it'll be interesting to see like where they fit and how well they do and all of that. Are there any cases of the vaccines causing rejection? That has been looked at, and I have not heard of any cases that I really could tie to rejection. On the other hand, we are seeing some rejection primarily in kidneys, but because people get COVID and then they reduce the immunosuppression and they juggle the immunosuppression, and we've had problems there. So I would say all of this favors getting the vaccine, trying to protect yourself as much as possible. But I wouldn't avoid vaccine because you're worried about rejection. You should be more worried about real disease and management thereof. Okay, heart transplant recipient. I had very high antibodies on the Hopkins assay 3 months after the third vaccine. Should you wait longer than the 5-month interval? No, you should do what we recommend because yeah. And no, so you should go ahead and definitely get that booster. Should I seek a full dose of Moderna for my 4th booster or switch to Pfizer? Hopkins seems to be recommending a full dose booster for transplant patients. We don't fully know the answer to that. You can't, I don't think you'll actually be able to get a full dose of Moderna for your 4th booster because the booster Moderna is half dose. So when you go into CVS, they follow algorithms. So they're just going to say, yeah, you're getting booster dose, which is 50 micrograms. So if you do want a full dose, I'd go with Pfizer. Totally fine to mix and match. Totally fine to mix and match. Like you can do whatever you want. I actually wanted to mix and match. I didn't have access. I got Moderna, and then I wanted to go with Pfizer, but I couldn't get one. So then I had to go with Moderna again. I didn't like all that matching. I just think it's interesting to mix it up, but less than 5% of Americans are actually doing the mix and match program. But I think given that you can have a full dose, I might go with Pfizer, but I don't feel so strongly about it. And we don't have medical data to suggest that that's important to do. The infection, can transplant patients feel safe unmasking in public? That is a really hard question. Especially now that we are in a time when we are about to open up. You know, the schools are going to open up. They're going to take away a lot of the mask mandates. It's been, in some ways, what we've actually just been through has been easier, right? Your friends and family, everybody got the memo, right? Everybody was on board, like, well, almost everybody, but you know what I mean? Like society as a whole, the grocery store, you know, everybody, we're all good. I actually think it's going to be harder moving forward because people are still going to be at risk. So like, at what point, you know, it'll be a lower risk, but there will still be risk. So I don't know when transplant patients will feel safe unmasking in public. I don't know when I'll feel safe unmasking in public, right? So I don't, that's kind of, we're just not there yet. I guess when would someone feel safe, feel that it's okay to get infected? We do have a lot more treatment options. Like I'm still trying to avoid, I'm not a transplant patient, I'm still trying to avoid getting infected. This disease is going to be around for quite some time. So it's a hard one to answer. I'm happy to discuss that further and give any guidance or whatever I can do to discuss it. It's a tough one. I think I have the feeling that many of us in Massachusetts may be wearing masks for quite some time to come. But the risk will get lower. So you will be able to, you know, socialize more. Hopefully it'll get warmer. So you'll be able to be, you know, outside more. Hopefully numbers will continue to die down, but I can't really say what exactly is going to happen. And I think all of us are very leery of making promises that were previously made that then won't happen, as we know. And has the CDC officially issued recommendations for fourth doses for immunocompromised individuals? Yes, they, many months ago, they made a recommendation for a fourth dose. Many months ago, it was 6 months after the end of the primary 3-dose series. Then they went to 5 months. Now they're getting to 3 months, but that's not official. So right now the official guidance is 3 doses plus a booster 5 months later, and that's been out for months. And then, great, Glenn, you're saying, okay, good, you got your Pfizer. Is having a PRA of 8 for IgG total HLA labs a contraindication? No, there's not. That for Judith, I don't know that to be a contraindication. I guess I would say talk to your treating heart transplant doctor, but I don't believe that that would be a contraindication of any kind I'm familiar with. If your doctor wants to talk to me, I'm happy to talk to them. That would not be a contraindication for me. In fact, if somebody is sensitized, which means they have antibodies to other people and it puts them at higher risk for antibody mediated rejection, perhaps they actually need vaccines more, because if they get COVID, we're going to reduce the immunosuppression and that's going to be a higher risk for rejection, right? So it's all of this is like thinking about the risks, the benefits, like which way, which way to go with all of this. And we've seen just tremendous, tremendous safety with all of these vaccines. I know that you hear about every single time there's like a tiny something in the news with vaccines, but we have vaccinated billions of people now, literally, and the safety data are incredible.
I was going to say that I had my first dose in January of 21, second dose 3 weeks later, third dose in August, 6 months later, all Pfizer. And then I had a Moderna shot on 12/29, which was 4 months later, but they really didn't want to give it to me. I had to really push them to give me the fourth shot after 4 months. So 2 things come to mind. First, and that was only a half dose of Moderna, so I have mixed them at this point. Should I get another, 12/29, it's only been 6 weeks, but should I go and get the Evusheld or Evusheld?
So you certainly could have, for any reason, has anybody, so I'm impressed you were able to get them to give you that.
Nobody's offered. I've been pushing because we travel quite a bit. And I actually wanted to get the Regeneron shots before I traveled, but it doesn't, I guess they said it didn't make sense. They only are giving those out if people are in the hospital.
Oh yeah. No, I was saying I was impressed that you were able to get somebody to give you the vaccine at the end of December. You must have a strong.
I have a big mouth.
Congrats.
I mean, in a nice way. I just kept pushing and saying, look, I'm just not comfortable, but I've got these plans and I really want to go. So what do you recommend? And they said, well, get another vaccine. So that's what I did.
Okay. So you actually fulfilled the 3+1 perfectly, and you should be good and done. I would get Evusheld if I were you, just
okay.
if you're like, why not? Well tolerated.
Okay.
It's
but
free.
This is fairly new. I've never even heard of it until you brought it up earlier tonight. So this is like brand new, or it's been around and I just haven't heard of it.
Well, monoclonal antibodies have been around for a long time now. Like it's something that we use in so many different ways. Many of you would have had monoclonal antibodies as part of your transplant. Monoclonal antibodies are pretty rampant out there. And, I'm personally giving injections in clinic. So like, I see that it's really well tolerated. Like people are like, this is fine. Of all the things we do to transplant patients, getting a cc and a half, so that's like a quarter teaspoon injected into, I do the arms. People are like, this is nothing. Like, so, and it's well tolerated. So I would do that, talk to your transplant team, see what they have available. It had been in pretty short supply and we have been scrambling to roll it out.
So it's not available at CVS or anything like that. It's got to be done at the hospital.
No, you'd have to go. Yes. I don't know that I've never seen monoclonal antibodies given at CVS. It's a little more advanced than that. Is my understanding. I don't know. CVS has done a heck of a lot in the pandemic, so like I can't promise, but for now I would double back and talk to your transplant team about it, and hopefully they can get it for you. It's just that it's like really well tolerated. What we don't know is how much protection it really provides against Omicron. So far, we're seeing pretty good levels of protection, although I think that we're giving it to some of the most vulnerable people who still are probably taking good care. So it's kind of a catch-22. Like one of the things is a colleague of mine gave it to three of his patients had breakthrough infections after getting Evusheld. He takes care of very, very immunocompromised, much on the spectrum more immunocompromised than standard heart transplant. And he had 3 breakthrough infections. And he said one of his patients just literally like walked out of the office and said, like, I'm done, taking off the mask, living la vida loca. And he got infected like almost immediately. So like you cannot go to, I always say, I hope everyone is old enough, you cannot go to the discotheque, even if you get Evusheld. You all know what the discotheque is, right?
I do.
Yeah, you still can't go to the disco. I'm not going to the disco.
I don't know what the disco is either, but
Is that establishment in Boston?
Any discotheque.
Oh,
Didn't you guys like?
well, this is
remember-
from the 80s then, from the 80s, like
Yeah. 70s,
Okay,
I
got
think.
it.
I think it was
70s or 80s.
Yeah,
70s
see,
and
look,
80s.
we got a disco. Yeah, all right, disco.
Gloria Gaynor.
Yeah,
yeah. The place you go
Okay.
to dance. I get it. Yeah.
that you cannot go to the disco, even with all the vaccines. You know, we're just not going to be there yet. Wait, what does Pat
So I'm
say?
going to call Dr. Lewis and tell him that you are pushing me to get the Evusheld, and what do I need to do? Is he going to be a happy camper?
Wait, and who did you say, Dr. Lewis?
Lewis, yeah.
Oh, yeah.
He'll-
We're rolling it out. We're
We're
rolling
rolling
it
it
out.
out. Okay, I need to fly to Boston to do that. Okay,
Well, where are you now?
now I'm in Florida. Next week I'll be in Hilton Head.
So you know what you can do? So do you have a provider in Florida?
No,
So you can look, there's a map, there's a federal map. Let me actually look at what the map is called. It's pretty cool. So it's, you can Google this, COVID-19 therapeutics locator. And you might include DHHS. Department of Health and Human Services, and the feds are actually tracking all the antibodies and all the treatments, and it's pretty cool. So when I'm prescribing, I'm actually looking at this map, and they're tracking all the doses and where everything's going. So you might be able to find Evusheld down there in Florida or in the Carolinas. I just don't know how you're going to get plugged into a transplant program, but I don't honestly have that capacity from Boston. I have capacity for a lot of things.
probably easier just to take a flight to Boston. It's only a couple hours. So I'll speak to him.
So Dr. Cotton, we got a couple more questions on the chat.
Yeah.
Yeah, I'm sorry to take up so much time, but thank you.
Oh,
I mean, I think Anthony had an answer about the Evusheld or a comment. Yeah. Did you have some info?
Well, so let's just follow. We'll get to that. Let's just follow the questions in order.
I know how to get the Evusheld.
So here's from Bob Romer. I wear masks to the grocery store, and the wife does also. But if she brings the virus home, what chances do I have to getting it?
I would say if you are living with someone who has Omicron, it is a very high risk that you are going to get infected. It is a family disease. And if somebody in your family has it, it's a really high probability you're going to get it. So I'm a firm believer, like if somebody is doing things that are risky, I had an 18-year-old go to a New Year's Eve party and be an 18-year-old. So he got locked in his room, which apparently he likes. He gets food delivery from his mother. On demand. So what 18-year-old doesn't want to like avoid their parents? So yeah, but we did waves of quarantining in our family. And so if somebody seems to be participating in high risk behaviors, or if there's any concern for disease, separate immediately. One of the biggest things is like, do not sleep in the same bed with that person. Like, do not let them breathe on you all night. Like with COVID, I always say the biggest thing, there's been like a lot of mystery about COVID and how it gets transmitted. The bottom line is don't breathe each other's air. Like, don't breathe someone's air. So if like you're in a separate room, you're not going to be like, you're just not going to get COVID sitting in a separate room, but you get COVID sitting at a table together, indoor dining, taking off your mask, you know, anytime you're breathing other people's air, that's how you get COVID, and that's why it goes through families. Do you think that Evusheld could ultimately replace boosters in the general population? No, we're not going to do. Evusheld is not really perfect. It's kind of like borrowed immunity. It's kind of like partial immunity. It doesn't trigger your own body's immune system. That's why we love vaccines. Evusheld is like good protection, but it's not your own protection, and it will wear off over time. So I don't think it'll be for the general population, but I will say that many of my colleagues and I are kind of mumbling about, for people who have suppressed immune systems, and we sort of haven't figured out exactly who that's going to be, we're probably going to go to vaccines plus Evusheld, or whatever monoclonal is appropriate at that time. Now, Regeneron got taken off the market, and the FDA said stop infusing it because it was not effective against Omicron. So that happened in like December, and they actually seriously had to tell the people in Florida to stop infusing it because it wasn't working, even though they kept using it. So we're going to have new monoclonals. We're going to have new things that roll out. Like, we're going to adapt to the times, and hopefully we'll get better and faster. And like, look where we are now compared to a year ago, right? Like, we're pretty awesome. These vaccines are a medical miracle. Like, we have saved millions of lives. We are awesome. And now we have monoclonals, and now we have antivirals, and that's going to get better. Like, every month, we're just going to get better and better and better. So hallelujah, like hallelujah, right? I don't know what to say about Pat Sullivan. Reuters just reported that mRNA shows more heart side effects, but not cancer patients, 72% higher of heart failure. I can't really tell Pat what that means, but
Reuters, it just came on a news flash on my phone.
Well, so we see much higher risks of myocarditis and heart failure in people who get COVID. So I'm not worried from the vaccine.
Okay.
And that was in basically young men who got rapid succession vaccines. We've now learned that we're going to spread out the vaccines a little more, decrease the risk of myocarditis. I have not seen myocarditis in any transplant patient. On the flip side, I have seen pretty devastating illness in some transplant patients. So I would not worry about, again, there's so much messaging around side effects of vaccines that I see tons of people coming in going, just before they get put on a respirator, well, I thought I wasn't supposed to get these vaccines because of side effects. Like, so that messaging is just wrong. And people who are propagating the messaging have blood on their hands. So I don't know what that thing is. I'm sure it's a different, but I can't tell the science from that one. So I can't really comment on that one, but just don't go with like, I'm going to get myocarditis from the vaccine. Cause
I'll forward you the article.
Sure. Great. Happy to read it. Is there concern inside the CDC about the new Omicron variant? Yes, there is. We're concerned about that variant and all future variants. We're not high level concerned yet today, but we are cautiously concerned because one of the variants is more contagious. Like, this is one of the most contagious viruses we've ever had, Omicron. And one of the new variants is more contagious. I'm like, you can't make this up, but let's not talk about that. Maybe it'll go away. Let's not talk about, let's not worry about that until it goes away. And how long will Evusheld last? Do we need to repeat? You will need to repeat but you won't repeat probably with Evusheld, because by the time you get to repeating, there'll be something new. So you won't repeat. Like we'll just have to, because we have to learn to be better, faster, smarter than the virus. Evusheld is a long-acting antibody. and in theory, it can provide 6 to 12 months of protection. However, it has diminished protection against Omicron. So we're thinking it's at least a few months, but we don't really know the answer to that. And we will eventually see it wear off and have more breakthrough infections. But I think that there will be a really good combination of like, you know, we're getting these vaccines, there will be boosters, there will be better boosters. We will figure out, different types of booster vaccines. We will figure out better monoclonals. We will, better treatment options, how to best manage immunosuppression in people who get sick. But I will say, I mean, at the end of the day, what I really worry about is that transplant patients are going to be still vulnerable to COVID-19 infection. Hopefully a lot less as it washes away, but this is like here to stay. And so this will be something that we will continue to kind of struggle with.
So here's the next question. Is the same recommended schedule for vaccines in place for VAD patients?
That's a great question. So VAD patients would fall under the standard vaccination. So that would be 2 vaccines plus a booster 6 months later with either Pfizer or Moderna.
They're not immunocompromised, right?
They're not unless, usually they're not immunocompromised, but unless they're on like prednisone or mycophenolate mofetil, also called Cellcept, or any of those things, which is unusual. So usually not.
Okay.
I safely be indoors with my kids and their newborn twins if they have lots of exposure from unboosted in-laws who are always there in a toddler and nursery school. What's the best argument for getting people boosted, vaccinated, who are not inclined with the Omicron variant being transmissible regardless of vaccine status? Oh, yeah. That's a tough one. I don't think you can safely be indoors unmasked, to be honest. I'm really sorry. So I think you can go by and visit, like if you want to go by and visit with an N95. I actually have a transplant mandate at across Mass General Brigham. Probably some of you have heard about that. We've been in the news lately. We've had protesters at the Brigham. You know, we just a second. No, my dog wants in. You know, the pandemic, right?
Yeah.
Spoiled. So we have a transplant mandate. We try really hard to practice good science. Like, we are saving lives. And so the transplant mandate has helped us enormously, because we just said, like, this is, you know, we need to protect you. We need to protect you, and we need to protect everyone else in the waiting room, you know, everyone in clinic, everyone in the hospital. Like, we need to protect our transplant village. It's really hard. And I sympathize. I think all of us have family members or people we know or people out there who are not pro-vaccine. And it's hard. It's really hard. It's, yeah, we talk a lot about it. In the beginning, we had a lot more success flipping the anti-vaxxer, or people, we call them vaccine hesitant. So we could flip a lot more people, but it's actually become really hard. So my heart goes out to you. I'm in kind of the same boat in that I have a lot of people I can't, you know, get vaccinated, even some transplant patients, which is heartbreaking. I see awful things. Great question. If you have had COVID, how much more are you protected than just vaccine? So yes, so there are a lot of ways to get protection. Natural immunity, you know, having infection gives you some level of protection. We don't know for transplant patients how, but you definitely get some more, but we don't know a little. We don't really know the answer to that, because the only way to find out would be like to do what we call vaccine challenge studies, which is to expose you again. So we're not doing that. So, and then it's probably different with Delta and Omicron, but you probably have some more immunity. So then if you have vaccines, COVID, if you get Evusheld, or if you get Sotrovimab or other monoclonals, then you're about as perfect of a cocktail as you can possibly get. but we don't really know the answer to that question. And there's no way of like measuring it. I mean, when I say challenge studies, they used to do these studies, and sometimes they still do, where they give like cholera vaccine to college students and they put them all in a dormitory with a bathroom, and they give them cholera and they see like how many people get sick. Like those are called challenge studies, right? So we're not doing that. That's the only way to really answer that question. So we're not doing challenge studies. We do see people get COVID again and again. So that's one thing, is like some people are like, oh, I had COVID once, I'm going to be fine. That it's not necessarily true.
Are they-
Are the monoclonals being rationed, or is there a shortage? So there is a decreasing shortage. So initially we had an extremely short supply, and now we have pretty good supply. And at least in the Mass General Brigham program, you should be able to contact your heart transplant program and come in for a vaccine. It's actually pretty hard. We need to like do the injections and observe for an hour afterwards, because that's what the regulatory people said we have to do. So it's kind of hard to figure out how to get it all done. But my understanding is within MGB, that rollout is happening. And then it looks like it's happening at Tufts. And we all figured out like our highest risk populations and tried to focus on them, and then kind of give it to everybody else. So it is rolling out actively. You could actually look at that website that I mentioned, that one that was the COVID-19 therapeutics locator. Actually, wait, I can copy this into the chat. And that's actually pretty cool, because you can actually see the number of doses of Evusheld. One of my patients was actually tracking it, and she would send us messages saying, I know you guys just got 700 doses. And I was like, oh, did we? Like, thank you. I don't know.
How's she doing that?
You know,
Yeah,
I don't know. Maybe off that website. I don't know. I didn't ask her. I was kind of freaked out.
Yeah.
You know, like it's spooky out there. I still wonder how my Zappos shoes come so quickly. I'm impressed with Amazon. I don't know. I'm still.
Yeah.
I don't know.
Any more questions for the good doctor? I can't thank you enough. I'm serious. This was phenomenal. It's got, I mean,
yeah. Camille,
I'm
thank
happy to be here, and I'm happy to, anything I can do to help prevent people from getting sick. But also, you know, one thing I would say now is like, so hopefully disease will die down. Hopefully we will all have a lot less disease in our communities, a lot less exposure. So let's take this time to embrace that we've had probably a lot of vaccines, maybe some Evusheld, maybe some natural disease immunity. We have some good treatment options. And I'm not saying that we should do risky things, but maybe now's the time to like live a little more safely. Like maybe think about getting out a little more, maybe going on a day trip, maybe I didn't address travel. I don't know if you want me to talk about it or if you want me to stop talking. You want me to talk? Okay. So one of the things with travel, I actually think that like, as disease dies down, you can travel, you could stay in a hotel room. I don't want you hanging out in the lobby, no indoor dining. My rules with travel are the eating is where things break down. So you can be outdoors, you can be in your car, but the minute you're anywhere indoors, you need to have a mask on. No indoor dining. We're not there yet. I don't know when we're gonna be there. I don't know when I'm gonna be there. Okay, so we're just not there yet, because that's the risky part. So when you're traveling, if you're eating, you get to eat lunch in your car, you get to eat lunch at a picnic bench or on a curb somewhere, or sitting on a wall overlooking an ocean, or in your hotel room. Takeout is great. There are lots of good takeout options. If you're flying, N95 the whole time. Eat before you leave the house, eat and drink a lot. Don't take off that mask the whole time you're in the airport, on the airplane, when you get off the airplane. And then, you know, if you're in Florida or whatever, you could do takeout food, just not indoor dining. You could do some outdoor dining if you're somewhere warm. How do you guys feel about that?
So you got me thinking. My wife,
Yeah.
my wife's visiting her mother in San Diego. Now she's pretty cautious, but and she's coming back in a week. Should there be a quarantine period between me and her?
Well, depends on your level of risk acceptance. That's like a really personal thing. So Omicron infections happen pretty quickly. So you could probably live separately or mask. This is a very personal thing. Like some people are like, I'm just not going to do that, which is cool. That's cool. But some people are like, I want to do that. Turns out some people also don't really love their spouse that much. And so they're annoying. Like, so I don't know. Sorry, the spouse can't hear me. Dog better not tell him I said that. But in the pandemic, we've all been living pretty close together. So sometimes that quarantine is like a relief. You could quarantine, you could be separate or masked or whatever, and then do some testing. And then she could do some like rapid testing on day 3 or 4. And if she's negative, she's good. But you don't have to. Like if she's cautious and masks the whole entire time on the plane coming home, and if she feels well, you don't have to. But it's like, what is your level of risk acceptance? So I can't promise she'd be fine. And I don't know what she's really been doing in San Diego, but like if she's visiting her mom, she's probably pretty careful. And so like, it's kind of up to you at that point.
All
But
right.
if you wanted to be ultra cautious, that's reasonable to think about. Yeah, Phil is asking, how reliable are home tests? So home tests are not very good unless you have symptoms. And I would actually, I'm glad you brought that up. That's one of my favorite questions. I feel like we got sold a bill of goods on the home tests and that we could all have Christmas with our loved ones if everyone just did a rapid and it would all be fine. Turns out it wasn't fine for immunocompromised people. And I saw a lot of people that were like, we all were rapid negative. And some people got life-threatening illness from that. So I actually don't like that for asymptomatic people without symptoms, they don't work very well. I've had a lot of people do rapids like again and again and again, and they're like sick. They clearly have COVID, sick. And they do like 4 and the 5th one's positive. So I'm not the biggest fan. I'll tell you what, I have them in my house and I have used exactly one because one of my kids needed it to go back to college. So I was like, oh yeah, you can use that one, just do it and we'll take a picture so you can go back to college. Otherwise I have not used mine at all because I just don't really, although we've done a bunch of PCR testing mostly because we needed to for like regulatory reasons, but not the biggest fan. I feel like they give you a false sense of security and that bothers me. Like, it just bothers me. Back like 10 or 20 years ago, 15 years ago, we were doing these mouth swabs for HIV. And we were like, they're like pretty good. But that didn't seem like the best idea. And some people were using it in like dating circumstances. And I was like, well, that doesn't seem like the best idea if it's like not very accurate, right? Like, so I get nervous. Does that answer your question, Phil? Or some are better than others. We don't really know what the best ones are. There are some ones that are recommended. I think they're on the CDC.
I just didn't know if
website.
they've gotten any better because the one I took that showed that I was negative obviously didn't work.
Later, it was positive.
Because a few hours later I was positive. So
Yeah, they're just not. No, they haven't gotten. The technology is just like not brilliant
I was
technology.
told that they weren't picking up the Omicron variant, is what I was told.
Yeah, they're a little less good with Omicron, but they're just never that great.
I'm not going to depend on them then.
Yeah, I would not.
I haven't gotten my free ones in the mail yet either. I don't know. I signed up a while ago. Has anyone got them in the mail yet? Because I haven't.
Yeah.
I haven't seen them.
I decided I wasn't going to sign up actually. And I'm like a pretty frugal New Englander. I like free stuff and I didn't sign up because I was like, I'm kind of done with that. And my friend convinced me to get a bunch on Walmart because she like made me crazy one day. I just think I don't know. I really worry that they give a false sense of security. I've had people offer like, let's get together for dinner. We'll all do a rapid.
Yeah.
I'm just like, I don't know. I worry that gives, I don't like false sense of security. That makes me nervous.
Okay.
So, yeah. So I hope you guys, I would encourage people though to get out of the house, go on drives. I know it's cold. Go on little outings. My family was supposed to go to New Orleans over the holiday break, but that fell apart because of Omicron. So instead we went to lovely coastal Rhode Island, Newport. You know, you can kind of tour New England a little bit, or New York, or for those of you not here, or Glenn, you're going to Carolina anyway. But, you know, get out, like, do take care of your mental health as well as your physical health. You know, make sure you're going on walks outdoors, seeing when it is nice weather, you know, see a friend for a walk, see a friend to sit outside together. Do take care of your mental health. This has just been really long and really hard, and we're all kind of weird and locked up in our houses, or at least I feel I am. I get to go to work. You know, it's bad when you're like pumped to go to work for your social life. Yeah, so take good care of yourselves. I'm really optimistic that things are getting better every day with treatments and protection, and the pandemic numbers are dying down. So I'm really optimistic, but it is still, there's still going to linger there in the future. So just take good care of yourselves and your community. And yeah, thanks for
Thank you,
being
Camille.
here. Sure, pleasure.
Thank you,
Take care,
Camille.
guys.
Doctor, thank you. Thank you very much.
That was
Pleasure.
fantastic.
And thank you to you for putting this on. HeartBrothers, thank you.
Yeah, they're
Very
great.
You're
They're
welcome.
great.
This was good.
Thank you, Camille.
All right, thanks, everybody.
Take care.
Thank you.
Okay.
Bye-bye.
If anybody wants to stay on and chat among ourselves, I'm going to stop the recording now. And we
Okay.
can continue to do that.
We had a bunch